Join me in welcoming Anna Novais, the Executive Director of the Rhode Island Department of Health in Providence, Rhode Island. Anna?
Come on out. Thank you. Thank you. So, 20 years ago, when I was new to public health in America, I had the realization that will change the way I looked at my life, personally and professionally. At the time, I had recently immigrated from Cape Verde, and I was working at the Department of Health as an education and outreach coordinator. Part of my job was to teach parents about the dangers of lead in their homes. At the time, we were seeing a staggering number of cases of lead poisoning in children that were causing great harm to their young brains and lungs. With the best of intentions, I talked to those parents about the dangers of lead in peeling paint and lead in the dust. But the fact is, those parents were going home to dilapidated apartment buildings, many of those owned by absentee landlords who did not care about the conditions in those homes. Many of these in neighborhoods that were cut through by freeways that were poisoning the air. Those were some of the many conditions in the homes and neighborhoods that affect the health of the families. And then I realized something else. I was going home every night to my 2-year-old son, living in basically the same conditions. Those factors in the homes and neighborhoods that were affecting and compromising, eating away at the health of the families we served, were eating away at the health of my own family. That moment, that realization, it's when I truly understood in a profound personal way how inextricably linked poverty and poor health outcomes are, and that it will take tremendous structural changes in public health for us to be able to truly impact the health of families with low incomes living in communities who lack resources. I mean, kids who live in unsafe neighborhoods and poor housing, they lack access to affordable quality schools, to nutritious foods. Kids whose parents struggle with employment and with finances are more likely to develop disease and have lower life expectancies than those of their more affluent peers. A Rhode Islander who does not graduate from high school will live 7 years less in average than a Rhode Islander who does graduate from high school. And as most of you here today know, for the first time in 200 years, the next generation, my children, your children, they have a lower life expectancy than we do. Just think about that for a minute. Our children's generation have a lower life expectancy than we do because of poverty-borne disease. That is absolutely unacceptable. Now, not all statistics are this bleak. Rhode Island, like many other states, has made strides and improvements in public health for the last decade. Tobacco rates have improved, and our adult smoking rates are now at 15.5%. Our adolescent rates are at 4.8%. By the way, the lowest in the country, so you know. And responsible sexual behavior in adolescents is also improving, where we can see a drop in teen pregnancy rates by 41%. Sadly, we've made step backs in other areas, and overweight and obesity have gone up 16%. Diabetes and hypertension had followed suit, and more people, particularly people without jobs, are suffering from behavioral health and mental health conditions. How can this be? How did we manage to go backwards? And how have we become so complacent with these absolutely dire statistics? So it became very clear to us at the Department of Health that we needed to do something different. We needed to change course so we'd not find ourselves a decade later having the same conversations, asking the same questions, seeing further decline in the health outcomes of the people we serve, seeing life expectancy shrink. We've known all along that many forces beyond genetics determine the health of an individual. We focus on the way today's experience and exposures affect tomorrow's health, and on the ways key periods in one person's life, from infancy, early childhood, adolescence, impact your health and are critical, particularly critical in laying down foundation for lifelong of health, mental and physical well-being. And we need to look at how the broader social world of education, employment, crime, housing, transportation, all impact an individual's and the community capacity to be healthy, as it was so well demonstrated by all the talks so far. What we didn't do was turn everything that we knew into a dynamic, comprehensive strategy that will tackle health problems in all fronts. What we didn't do was concentrate resources to address those community issues that were so broad. So we shifted gears. We partnered with community organizations across the state. We moved from a siloed, disease-specific approach to one that is community development focused, place-based, that relies heavily on community input and community engagement. We took discrete pots of funding that we used to address obesity, tobacco, and we pooled them together to address those community issues more broadly that were creating and perpetuating the inequalities in health that we wanted to see changed. So now, the upshot of this shift is that Rhode Island Department of Health is partnering with organizations across the state to create what we call the health equity zones. Those zones are geographically areas where we harness local energy to tackle on the determinants of health. Those zones are zones where we have communities coming together strongly. Today, we have 10 vibrant health equity zones in Rhode Island, led by 10 strong backbone organizations such as LISC, where we are seeing more relationships being forged on the ground, leading to changes at the neighborhood level, and leading to environments that create and support not only healthy choices, but healthy living for all of its individuals. On a sense, the work that LISC had done in Rhode Island in building sustainable communities served as the blueprint for this initiative because we could see how effective that work was in creating community engagement and in mapping out solutions at the local level. The health equity zones gather together stakeholders from City Hall to community-based organizations to church to business to health centers, but more importantly, residents, to determine what health means to them, what priorities do they want to address, and what strategies will get them where they need to go. You see, in Central Falls and Pawtucket, which is the health equity zone led by LISC, they have ramped up work to connect residents to jobs, to support small business, and to address adolescent health issues in the area of mental health. In Olneyville, which is a health equity zone in the city of Providence, they are taking on transportation, property redevelopment, they are doing lead mitigation, and they are doing financial stability for its residents, while they are also addressing diabetes by creating community and clinical linkage in that region. So you see, Rhode Island is the smallest state, geographically, in our entire country. And we struggle at times to act both at the micro and macro level. But we absolutely rely on partners such as LISC, on these collaborations that we created, to create the infrastructure at the local level, where it's our local voice, and where we have their support to carry out with implementing those strategies that will help the people and the places they call home get healthier. Does achieving health equity seems like a pipe dream to you? In Rhode Island, we don't think so. We believe that by partnering with many, many agencies such as LISC, by listening to our residents, by directing resources at the social determinants of health, by bringing social justice to bear on the underlying causes of disease, we believe that we can do it. At the end of the day, getting to good health is a collective project. And as a society, we do have the responsibility to make sure that all children, no matter where they start, have the right to a good education, a safe, comfortable home, a pathway to achieve their potential. That every child has an equal chance for a productive and healthy life. That's equity. In Rhode Island, we believe in it. I hope you believe in it too. And I hope you join us in making it a reality for many, many other children. Thank you.
Anna, when I first met you in Rhode Island and I asked you, what are the two top issues that impact health in Rhode Island? And your answer shocked me, but I knew at that moment that we had a lot of work to do and that you were trailblazing, that you were going to get us there. Because what you said was the two big issues were the lack of jobs and the lack of education. And that if we could tackle that we would be on our way, because that was impacting the quality of our health in the many of the communities that we serve. So my question to you is, how many of your colleagues across the country understand the equity of health the way the Rhode Island Health Department does?
I would love to say that many, but unfortunately it's not the reality. I think folks understand folks understand the social determinants of health. We all have heard that, and it's in every proposal that comes out of the feds. I think the challenge has been how to turn that knowledge into a concrete plan of action. And so far, I do know that there are 4, in fact, initiatives that are similar to what Rhode Island is doing, that is trying to reshape how we do public health. And truly understand that when we talk about health in all policies, that is not just a catchy phrase. It means that you are sitting down in a variety of other tables and that you are creating the partnerships that you need to create in order to truly address what we know is causing the inequalities in health. People don't die of lack of education. People die of not having conditions in which to live healthy lives.
The questions. While they're thinking, is there a hand up?
In the back.
Okay, let's wait for the mic to get to the, okay.
Hi, I'm Ines Palmarin from Boston, LISC. What advice do you have for other communities or cities or states that would want to take on this approach? And then my second question is regarding the residents and empowerment. You said you work with them and listen to them. How do they help you sort of put the plans into action?
So I'm going to start with the question of the residents because I believe it's very important and it's a key component of the work that we've done. There is a tendency to think that from public health or other organizations that we know it all and we know it better, but we don't. And being able to truly believe and rely on the input of the community residents who tell us what is important to them and help prioritize that, it's important. In fact, I know that Carrie from LISC Rhode Island is here, and I know she has some of those plans of actions that were developed with community input, so you can find her in the break and she will show that and share that with you. But true community engagement with residents is important, so you can have it being owned. That impacts in terms of sustainability of the project when it's really shared ownership by all. As of where to start, we in Rhode Island started by truly pulling together all of those different programs and having programs talk to each other. By looking at the work that was already happening at the local level and be able to say, where can we start because there's already some energy going on. That's how we looked at the work that LISC was doing with building sustainable communities because that was already in the groundwork that was pulling communities together. And then it was seizing the moment, in fact. With the passage of the ACA, there was, as many of you probably know, a requirement for hospital systems to do a community needs assessment, to listen to communities and develop community benefit plans. So we engaged with them to say, okay, you need to do this, how can we allow? So it's seize the opportunities, start a conversation within the health department, and look at where you have already work going on at your communities that you can pull together and grow and expand and nurture that growth.
Another question?
Thank you. I actually want to pick up on your last point. As I listened to you, I was spending a lot of time contemplating the implications of the demise of the ACA to many of the things that we've been doing, where we're by no means as far along in embedding the value that you've embedded in the work you've done in Rhode Island. So I guess I would ask you, based on your experience, if you were working in a community where the combination of the ACA motivating healthcare to pay attention was just beginning to get people to pay attention to the value of what health means to the larger economics of a community, what insights might you have for those folks that keep that hospital system or that healthcare provider engaged when the requirements start to dissipate?
Well, I would say regardless of what happens with the ACA, that we are all praying that it's not going to go away, there is a clear understanding nowadays that for you to change the healthcare system in the United States, for us to truly achieve the results that we need to do, from both an economic perspective, we need to address the underlying conditions that are affecting the health of the people. Because if not, we're going to continue to have a healthcare system that is expensive, that continues to take care of the sick people and not truly create the savings that we need. It is an economic issue. Business can no longer afford the healthcare costs that we have in this country. We spend the most in healthcare costs than so many other countries in the world, and we have worse results as a nation. So we know we cannot maintain that status quo. So regardless of what happens, I think hospitals have understood that they need to do this as a way of surviving the environmental that they live from a cost savings perspective. But also, I would say, do not rely only on hospitals. We didn't do that. I mean, we rely on federal funding where we kind of pull it together that way, and we are seeking other private-public partnerships because it is a private-public partnership. We are working with housing to make sure that they support some of the activities that we cannot support. We're working with education to make sure that they support what we cannot. So you can start building and trying to find other partners that want to join in understanding that we are trying to improve the health of a community, improving the conditions of the neighborhood, and that is community development and that is economic development. So it's no longer a health or public health issue, it becomes a community issue.
Is there another question? Anna, did I see a question over there?
Yeah, this one.
Okay, go ahead.
This is going to be a little bit inside baseball, but there are other factors besides the ACA. One of those is the accreditation process.
Yes.
So is that how you arrived at the health equity zones, was through your own state health needs assessment and your own state health improvement plan? And I think can you speak that a little bit? Because the opportunity so accreditation, briefly, is a process by which states, counties, cities become more eligible for federal funds. Okay, everybody knows this. All right, never mind. So the question is, was that how you got to the health equity zones?
In fact, no. When we started this process, it had nothing to do with accreditation. We truly did it more from a focus on community health and on improving health equity. Accreditation came after. In fact, we sold it to our folks doing accreditation, saying to them, this is something that you can take credit for and that can help you with accreditation. But we have been thinking about it it has been a long journey, in fact, and accreditation came in after. But it's a helpful way to get there.
Anna, thank you. This is fantastic work.